Okay, guys, next session of Let's Cram It Conceptually. Repeat after me. So listen and then repeat. Now, first question. In emphysema, what is the investigation that we do to measure the lung volumes? So the answer is plethysmography. Now, why plethysmography in emphysema? Because in emphysema, air is trapped. So we cannot use gas dilution technique because the gas won't even reach those trapped areas of air. So we can't use that, and it will underestimate the lung volumes. So that is why we need to use this body plethysmography. Alright. So what gases are used in gas dilution technique? It's either helium or nitrogen. Then what about the other options in the question? We have DLCO, which is diffusing capacity of the lung for carbon monoxide, but that measures the ease of transfer of gas from inspired gas to blood, which gas especially using carbon monoxide, 0.3% carbon monoxide. That does not measure lung volume. Now the last option, transdiaphragmatic pressure. Now that is used to measure muscle weakness and an indirect measurement of FRC, functional residual capacity, especially in cases like myasthenia gravis. So the answer to this question, with emphysema, you use body plethysmography to measure lung capacities. Next question, GOLD staging. Now what is GOLD? Global Initiative for Lung Disease. And what is it used for? For assessing the severity of COPD. And what is it based on? It's based on spirometry values. And what values? So two parameters. One is the ratio between FEV1 and FVC. Now what is FEV1? Forced expiratory volume in the first second. That means how much forcefully you can expire in the first second, in 1 second. Now FVC, forced vital capacity. Now what is forced vital capacity? You inhale first to your full capacity and then forcefully you expire. In your entire breath, how much you are able to push out, that is FVC. So FEV1 by FVC ratio is taken into account in GOLD staging. So what is a normal FEV1 by FVC ratio? Around 70%. And the other parameter that is used is the FEV1 compared with the predicted FEV1, the measured FEV1 compared with the predicted FEV1. So this is GOLD staging for COPD. Now question number 3. Bronchiectasis most commonly involves which lobe of the lung? So we have in order 1, 2, 3, most commonly left lower lobe, second most commonly right middle lobe, and third most common lingular. So what is the order? Left lower lobe followed by right middle lobe and then the lingular. Now upper lobe bronchiectasis, when you see unilateral upper lobe bronchiectasis, most common cause tuberculosis. However, if you see bilateral upper lobe bronchiectasis, look for cystic fibrosis or ABPA. What is ABPA? Allergic bronchopulmonary aspergillosis. Now, middle lobe and lingular bronchiectasis. It is when the lung is infected by MAC. What is MAC? Mycobacterium avium intracellular. Now, lower lobe bronchiectasis, most commonly seen in children with immunodeficiency syndromes. Alright. Now, let's also see which lobes are involved in the pneumonia caused by these two organisms. Now, Klebsiella causes upper lobe involvement, pneumococcus lower lobe involvement. Again, Klebsiella upper lobe pneumonia, pneumococcus pneumonia lower lobe. Coming to the last question, Mycoplasma pneumonia drug of choice. So the drug of choice is either macrolides or doxycycline. Now macrolides, what are your macrolides? Azithromycin, clarithromycin, erythromycin. Now quick note, what do they bind to? Mechanism of action, they bind to 50S ribosomal subunit. Yes, macrolides. Now doxy binds to 30S subunit. So these two are the preferred drugs. So in my question, the answer would be doxycycline because we didn't have azithro, clarithromycin or erythromycin. Now a small quick note about Mycoplasma pneumoniae. Now this is the most common community acquired pneumonia in adults. Now what are the other names? It's also called as Eaton's agent pneumonia because the organism is also known as Eaton's agent, remember? Yes. Now, although there are a lot of causes of atypical pneumonia, Mycoplasma pneumonia is considered as primary atypical pneumonia. And it's also called as walking pneumonia. Now, what do you find on chest x-ray? It's primarily peribronchial involvement. So, you will see prominent bronchial markings. And coming to the organism itself, it lacks a cell wall. Okay, so microbiology, you can't see it on gram stain. And pharmacology, that is why we are not using penicillins or cephalosporins. They won't act because the cell wall antibiotics, the beta lactam antibiotics will not act because they don't even have a cell wall. So that is why we are giving drugs that act on the protein translation. So macrolides and doxy. Where do macrolides act on? 50S ribosomal subunit. Doxy act on 30S ribosomal subunit. So that's it for now. So you repeat after me slowly and again.